So my colleague Yazid Sawala from Ohio State came up to me with the idea of looking at the experience of Venetoclax outside of clinical trials. So we published a phase 2 study, prospective study, using Venetoclax in patients with Waldenström's earlier this year in JCO. And in that study, we saw that it was about a 19% VGPR, and patients had a median progression-free survival of about 30 months. But obviously, we all understand that there are differences between the patients who participate in clinical trials and the patients that actually are out there in the community. So Yazid was able to collect data from at least 3 or 4 dozens of patients with Waldenström's previously treated that were exposed to Venetoclax as monotherapy outside of the context of clinical trials, and try to understand, how these patients, number one, respond, what is the toxicity that they have, what is the benefit that they obtain. And it was interesting to see a couple of interesting messages. I mean, one of them is that in the clinical trial, we went up to 800 milligrams daily. That was the maximum dose. Outside of clinical trials, in the community, few patients actually reach the 800 milligram dose. Most patients are between 400 and 600 milligrams. And I think that is driven by the fact that in patients with CLL, which is the condition in which we use Venetoclax the most currently in the United States, the max dose is about 400 milligrams. So I think that translates into managing patients with Waldenström's in the community. What we have seen also is that in the trial, the median number of therapies, previous therapies were 2. For this study was actually between 3 and 4. So it looks like the clinicians in the community are waiting a little bit longer to actually expose patients to Venetoclax rather than earlier in the disease process. And I think that for that reason, the response rates were lower in the off-trial setting, and the benefit was shorter compared to the patients in earlier stages. And I think that makes sense. It's very compatible with our observation in the clinical trial, in which we saw that patients who had been exposed to Venetoclax, either in the first relapse or the second relapse, did better than the patients who had a third relapse, for example. Most of these patients were in third relapse, so basically it mimicked that experience that we had. My sense, obviously, is if we use Venetoclax earlier in the treatment of patients with Waldenström's, I think those patients might benefit the most. If we wait a bit longer, the patients will benefit less. But I think that is a very common observation that we have seen throughout when we try different types of treatments. So I think that's an interesting aspect of things. So we will be expanding the evaluation of the database, looking a little bit deeper into adverse events and other potential issues associated with these therapies. But I think Venetoclax is an up-and-coming treatment for patients with Waldenström's.